blood vessels cause damage as they pass. Spleen removes the damaged red cells from the circulation, and microcirculation develops in numerous thrombi. Clinical manifestations preceded by a prodromal of gastrointestinal infection and diarrhea, sudden onset of pallor, bruising, purpura. Treatment is maintain nutrition, hydration, dilute toxins, control hypertension, hyperkalemia, and seizures. When renal failure occurs, treat with dialysis. Blood transfusions with packed red blood cells are needed to maintain and recover hemoglobin. Most children recover. Nephrotic syndrome, a group of symptoms characterized by proteinuria, hypoalbuminemia, hypolipidemia, a minimal change in neuropathy, effusion of epithelial cells. You can have focal segmental glomerular sclerosis, and it's primary and idiopathic, meaning idiopathic, we don't know, and secondary, meaning it's related to some other disease process. So congenital nephrotic syndrome, Finnish type, is caused by autosomal recessive mutation, and lack of protein is expressed before 3 months of life. Infants do not respond to steroidal treatment. Clinical manifestation: periorbital edema, edema of intestinal mucosa, signs and symptoms of malnutrition, increased susceptibility to infection, irritability, fatigue. And this is a picture of a child with nephrotic syndrome, periorbital edema, swollen facial muscles, scrotal edema, and legs. See, the legs are swollen also. Treatment, because one of the reasons for nephrotic syndrome, remember, always causes loss of albumin, even in children, and they get dissension and ascites just like adults. So that's why they have that edema. Sometimes you see this in adults. Everybody gets nervous about it, but eventually, if the underlying cause of the problem is adjudicated, then it disappears. Treatment: reduce excretion of proteins, maintain protein-free urine, treat infections, glucocorticoids, prednisone, maintain low sodium, well-balanced diet, provide skin care. Edema becomes prevalent and administer diuretics, and ACE inhibitors, and administer non-corticosteroid immunosuppressive agents. Edema with nephritis is associated with increased immune-mediated AG vasculitis, aldosterone, plasma onconic pressure, or ANP. Atrial lipid. What's the answer? 2. Edema of the intestinal, the movement of fluid from the vascular intestinal space can decrease blood volume and increase activity of aldosterone and decreased and leads to a decrease in the ANP, and therefore the edema develops. Okay, rare in children, kidney injury, pre-renal, dehydration, hemorrhage, sepsis, intrinsic glomerulonephritis, hemolytic neurotic uremic syndrome, hypertensive reaction to drugs, infection, post-renal, obstructive uropathy such as posterior renal valves and obstruction of renal junction. Pediatric modified rifle risk, RIFLE, rifle risk. So these are the chart, which is kind of nice. It goes through the different, what you would expect to find. I don't expect you to know that, but it's something they might hear mentioned about rifle, and the scores. Chronic kidney failure is very, very young children associated with congenital renal destructions. Chronic kidney failure is older children associated with glomeruloneuropathies. Treatment with end-stage disease, peritoneal hemodialysis, and kidney transplant. Wilms tumor is an embryonal tumor of the kidney, most common between the ages of 1 and 5. It's called nephroblastoma. It arises in proliferation of the abnormal renal stem cells. It's the most common solid tumor in children. It's composed of 3 cellular components: stromal, epithelial, and blastemic. It's inherited in sporadic forms in stage 1 through 5. And I've seen many children with this at Sloan Kettering and helped some do some of their cases. Some of the surgery was early in my career was quite dramatic. But now, with better chemotherapy, there's less loss of bladders and diversion required. And this is what Wilms tumor looks like. Wilms tumor 2-hit hypothesis. Children who inherit a mutation of one allele of a tumor suppression gene require just one more somatic mutation for tumor to grow. Wilms tumor suppression genes, WT1 and WT2, are located in chromosome 11. Remember, they have the Wilms. You need the Wilms tumor gene to form the kidney system. So one of these would lead to the second hit. Okay, that happens a lot in oncology and cancers. The 2-hit hypothesis. There are very few diseases that it actually fits completely into, but there are some. Treatment: surgical exploration and resection, chemotherapy by surgical resection, bilateral disease, heminephrectomy of loss involved kidney, radiation therapy, high stages of disease, and metastasis. UTIs, we're going to spend a lot of money, a lot of your time and efforts on UTIs in your primary care practices. And even if you're not in primary care, you're going to run into it when you're doing psych or you're doing family or you're in the emergency room. UTIs are a big problem. It's the colonization of pathogens anywhere along the urinary tract. E. coli is the most common one. Cystitis is an infection of the bladder. And so these are the grades of reflux: normal, slight, moderate, mild. And you can see the dilatation, right? Urinary tract infection, clinical manifestations: infants, fever, vomiting, diarrhea, and jaundice. If you get the fever, vomiting, diarrhea, you think it's the flu, maybe food poisoning, but jaundice is a dead giveaway. Infants and young children: fever, undetermined orange, possible presentation frequency or urgency, enuresis, inconsistent or incontinence of a previously dry child, abdominal flank or back pain, foul smell of urine, sometimes hematuria. Okay, acute pyelonephritis is clinical manifestations: fever, chills, flank pain along the enlarged kidneys, and edema. Chronic pyelonephritis is asymptomatic. Treatment is usually relieved in 1 to 2 days. The urine becomes sterile. Urinary tract infections: course of oral antibiotics administered 2 to 4 days of uncomplicated utilized longer than may be required. Education of families about signs and symptoms of UTIs for early detection. Surgical correction of vessel-ureteral reflex problem, or obstruction may be required. A child has a UTI, which assessment and finding is the most typical of the condition: enlarging asymptomatic upper abdominal mass, periorbital edema that descends into the extremities, prodromal gastrointestinal illness, and incontinence in a previously dry child. So we just said that, right? So the answer is infant children present with an undetermined origin, may present with urinary tract frequent urgency and then incontinence in the previously dry child. So previous dry child. Okay. Vesicorectal reflux is a flow of urine retrograde from the bladder into the ureters and kidneys. The reflux encourages infected urine from the bladder to be swept into the kidney, leads to pyelonephritis. It's caused by congenital abnormalities and eptopic insertion of bladder catheters. And these are the grades. Vesicorectal reflux. Urinary incontinence is involuntary passage of urine by a child who is beyond the age when voluntary bladder control should have started. Enuresis is bedwetting at night. And functional incontinence, urinary incontinence, with no structural or neurological abnormality. Enuresis theories, organic causes, maturational lag, genetic factors, sleep patterns, psychosocial theories. Clinical manifestations upon primary enuresis, child was never continent. Secondary, the child is continent but now is incontinent. Diurnal, nocturnal, or both. So the most common, I think, is nocturnal. That's from my experience. Treatment begins with education, daytime incontinence, behavior therapy, treatment, enuresis alarms, medications, desmopressin acetate tablets for bladder spasms. Renal urological system case study. A family of 4 attends a neighborhood party. A typical menu of hot dogs and hamburgers is served. A few days later, all 4 members begin to experience abdominal cramping and diarrhea. 4 days later, the youngest child, a boy only 3 years old, experienced bloody diarrhea. The mother takes the child to the hospital and been on a general care workup and diagnosis of renal insufficiency pending positive culture. 2 days later, the child is transferred back to a pediatric intensive care unit, and the concurrent respiratory is confirmed. He has HUS. So just to remind everybody about HUS. And